Hello, pharmacists and friends. Today is March 17th, 2023, and welcome to the Regimen, where public health pharmacists, pharmacy students, and our guests discuss the latest public health issues. Listen to find out how pharmacists and pharmacy students like me can improve population health, health equity, and patient care through advocacy and education. My name is Jake Lawrence, and I'm in my sixth and final year of pharmacy school at the University of Rhode Island, working with the Rhode Island Department of Health alongside my professor, Dr. Bratberg.
And I'm Jeff Bratberg. I'm a clinical professor of pharmacy practice and clinical research at the URI College of Pharmacy and the Academic Collaborations Officer at the Rhode Island Department of Health. The opinions expressed in this podcast by the hosts and guests do not necessarily represent the opinions of the United States nor the state of Rhode Island. So it's St. Patrick's Day, Jake.
I know, and this is the first podcast we've hosted where the sun is actually out. So
I know. Usually we bring the bad weather, but the sun is shining behind me here, so that's great. Great podcast last week on emerging vaccines, talking about RSV vaccines, very much needed. What did you think?
Oh, it was great, and I love having Dr. Matson on. That's really, her subject, pediatrics, new things that are coming out, treating sick kids. So it was wonderful to have her input and her to talk about her experiences that she's had this season.
All right. Well, the podcasts keep getting better. I don't know we have no ceiling on how good these podcasts can get. So listener, you're in for a ride.
We're very excited for today's topic of smoking cessation with two very special guests. First up, we have Anne DiGiulio, National Director of Lung Health Policy at the American Lung Association, and Julia Doherty, the Nicotine and Substance Use and Addiction Treatment Coordinator for the Tobacco Control Program at the Rhode Island Department of Health. So why don't we start with you, Anne? Introduce yourself, tell us a little bit about your role and what you do.
Thank you so much for having me. My name's Anne DiGiulio. I'm with the American Lung Association. I'm the National Director of Lung Health Policy here, and I direct our tobacco cessation policy work.
Awesome. Thanks for joining us. Julia, a little bit about yourself.
Sure. Thanks so much for having me. So in my role, I oversee the state quit line, which is 1-800-QUIT-NOW, a free evidence-based cessation service. And I also help promote systems change efforts to increase accessible and integrated tobacco treatment throughout the state. So for example, assessing cessation coverage, providing technical assistance, and helping to ensure educational opportunities for providers on best practices. And I'm situated within the Tobacco Control Program, which has the goals to eliminate exposure to secondhand smoke, promote quitting among young adults and youth, prevent initiation among young adults and youth, and identify and eliminate tobacco-related disparities. Thanks.
Awesome. Thanks again for joining us. We're super excited to have you guys on. We get two great perspectives, one on a state level here in Rhode Island, and then a little bit more of a national view. So I guess why don't we just jump right into it? Let's address kind of what the biggest problems and gaps are with smoking cessation, where it stands right now in the US and Rhode Island. Julia, could you expand a little on the state level?
So big picture, we know that tobacco use remains one of the leading preventable causes of death and disease in the United States. And in Rhode Island specifically, approximately 1,800 adults die from smoking annually. It also contributes to about 28% of cancer-related deaths in Rhode Island. So from the 2021 Rhode Island Behavioral Risk Factor Surveillance System, so we're looking at those who are 18 plus, the prevalence rate for cigarette use was about 12.5%. This is a 1% decrease from the previous year. And our prevalence for e-cigarette usage for adults was about 6.2%. And that's about a 1.5% increase from last year. So overall, we see trends for smoking prevalence are going down, but changes have been very incremental since 2015. And we see really persistent and significant disparities in communities that have been historically disproportionately targeted by the tobacco industry and may have other social, environmental, or economic systems impacting their usage outcomes. So for example, those with low socioeconomic status or those who report frequent mental distress have much higher rates. So just as one example, those who report frequent mental distress in Rhode Island are 2 times as likely to report cigarette use in 2021. So double the prevalence rate. And those who identify as LGBTQ or disabled, both of those 2 categories show a much higher prevalence of e-cigarette usage than the general population.
Yeah, it's frustrating to see such small decreases over time, especially in the last 7 years. And then again, targeted more so in those marginalized groups. And are you seeing a similar correlation on a national level with the American Lung?
Yeah, no, I think the national data very much tells a very similar story. We see cigarette use rates going down, which is great. I think right now the most current data shows cigarette use at about 12.5% of the general population. Unfortunately, those same gains have not been seen across the board. I think one of the leading indicators, kind of however you break it down, is really poverty. So whether you break that down by healthcare status, if you want to try to correlate education to wealth, that's another way to, the higher degree you have, the less of that population uses tobacco products and smokes cigarettes. Or if you look at exactly just the numbers of, how much money an individual makes. So, I think unfortunately we are seeing that. And then we also know the predatory behavior of the tobacco industry to specifically go after those populations that don't have the income, that don't have the resources, and that have historically been targeted and are continued to be targeted. And that is a huge problem. But people like Julia and her counterparts across the country are really working very hard and very diligently to really counter that.
I was going to jump in. I was very interested to hear your thoughts, Julia and Anne, about the mental distress. That's something I hadn't thought about before. Of course, 2021, I think everyone had a lot of mental distress, as the data shows, from COVID-19. And as I was just writing a paper earlier today about COVID-19 effects on different drug addictions, is that correlated directly with COVID-19, or is it mental distress? Or I know that mental distress has been going up, or at least diagnoses of mental conditions have been going up pre-pandemic and post-pandemic. So what are your thoughts on that?
So that specific language of frequent mental distress comes from the Griffith survey that I mentioned. So that really means they're self-reporting what they would call poor mental health for the majority of the days of the month. However, I will say there is national and historical data that people with behavioral health diagnoses do have higher rates of cigarette usage. So I think it's true historically, and then I think we need more data specifically in Rhode Island to bear out the impact of COVID. Definitely something that we're interested in.
I would say nationally, that is very true as well. Both historically and currently, we know people with behavioral health diagnoses have comorbid tobacco dependence issues. And so, I think that's another key population that we need to be aware of and to be ready to help. And, making sure that that population is also connected to the services that they need. I know we're going to talk a little bit more about treatment as we go on, but making sure that behavioral health facilities are smoke-free, that cessation and quitting tobacco is part of quitting other addictions. We don't want to reinforce other addictions with still allowing patients to keep using nicotine products.
Well, it's no secret that those of lower socioeconomic class and those with mental health illness or issues were affected the most by the pandemic. So let's talk about some of the benefits of quitting smoking, smoking cessation, or using tobacco alternatives.
I can jump in and start with that. So the quitting smoking is one of the best things that an individual can do to improve their health. I think that's a pretty obvious statement, but if you want the science, in 2020, January of 2020, right before the pandemic began, the Surgeon General released a Surgeon General's report on smoking cessation. And this was a really awesome report for a number of reasons. One of the coolest things was it was the first time that the Surgeon General had definitively found causal links between quitting smoking and health improvements and reduction of risk for certain things. So this is a really great way to, if you quit smoking, you reduce your risk of cancer and other health risks that you might have from smoking. We know that smoking causes everything from cancer, increases risks of, reproductive risks, increases risk of type 2 diabetes. And so, we're really excited to have these data and really kind of emphasize the importance of them. That report also laid out, a comprehensive cessation benefit. So that's 7 forms of medication. There are 5 nicotine replacement therapies, and then 2 medications, bupropion and varenicline, that have been found safe and effective by the FDA, which is the Federal Food and Drug Administration, to help people quit smoking. These have been, the most recent one was approved in 2008. So they're long-standing medications, as well as 3 forms of counseling. And having those available without barriers to access them and covered by insurance can really help improve cessation outcomes.
Let's talk a little bit about the over-the-counter items.
The nicotine replacement gum, patch, and lozenge are all medications that can be available over the counter. So you can walk into your corner drugstore or a major chain pharmacy and get those medications. However, and we can go into more detail in a little bit, but for most people, including individuals on Medicaid in the state of Rhode Island, if you get a prescription from your doctor, you can get that medication with no or low cost sharing. And the other 4 are all do require a prescription at any point to get those.
Julia, your thoughts on cessation access in Rhode Island?
Yeah, so going back to the lovely BRIFIS, the Behavioral Risk Factor Surveillance System, we do every other year, we get to collect information on self-reported access to cessation services. So are your doctors speaking to you about your smoking? So in 2021, people who currently smoke were advised to quit in 64% of their visits, which is a decrease from 2019. And similarly, they reported discussing quit medication in 41% of their healthcare visits, so a little bit lower. They might have been asked, but then even less likely to have discussed a quit medication. And then around in 52% of the visits, healthcare providers discussed non-medication quit strategies. So it's a slight increase from 2019. So that's overall, it's not stratified by insurance type or demographics, and it is self-report, but it is helpful to see there's a lot of room to increase in those numbers. And those numbers are also just for those who did see a doctor in the past 12 months. So we know that the rates for support are lower for those that maybe aren't engaged in consistent care.
Does the Rhode Island Department of Health have any data on Medicaid usage or utilization of NRT that available publicly?
So we are working on a dashboard for that. We just this year started collecting all payers database claims information to see claims data on both counseling codes and the cessation related medication codes. I'm not able to report on those at this time. Definitely something we're looking into as a way of tracking access.
I mean, it's wonderful that we have these options for adults. Again, things people can just pick up at a corner store or again, access via pathways by their providers. Would either of you be able to speak on younger patients, the youth in those 18 to 25 or even younger when people may start to pick up smoking?
So yeah, we know that the age of initiation is incredibly low. And that is one of the reasons that we are very grateful that we have the tobacco 21 age, so the legal age of purchase both in Rhode Island and across the country is 21 years old. Unfortunately, we know that kids still get tobacco products and still use them. And so, as you mentioned, kids 18 or young adults ages 18 to 25 are able to use any of the products that Julia and I referenced and should be encouraged to talk to their doctors about quitting. Unfortunately, these products have not been FDA approved. Again, that's the Food and Drug Administration for use for kids under the age of 18. And we know, again, a very alarming and unfortunate trend and sad trend is the numbers of kids using tobacco products, specifically e-cigarettes, but not exclusively e-cigarettes, and really higher levels of addiction than we've ever seen before when kids were using combustible cigarettes. So there's truly a need to try to figure out what to do to help these young people quit, because we know that they also really want to try to quit. Most people don't want to be addicted to tobacco, and this group is no different from that. And there's been a ton of industry marketing towards these kids to encourage them to use tobacco, so we need to do everything we can to make sure that they don't have a lifetime addiction. The American Academy of Pediatrics, which is really the absolute expert in this space, has created a clinical considerations for their clinicians. And it really kind of walks through how a clinician should talk to a child and or a family, depending on what's appropriate for them, about their tobacco use, as well as looking at ways to treat that, whether that be counseling, and then in certain circumstances, looking at the ability to prescribe NRT off-label. Again, it's an individual decision between a clinician and a patient and hopefully a parent or guardian that's involved in that child's life. And so I would encourage everybody, and I don't know if you guys can add it in the show notes, I'm happy to share that AAP's guide and would encourage anybody with additional questions, reach out to the American Academy of Pediatrics about kind of what that clinical consideration is, really kind of the framework on how to treat kids under the age of 18 with nicotine addiction.
And thank you so much for that. That's very, very informative. And I think that's one of the reasons we chose this topic for the podcast. Several of my other students were concerned about their family members and using e-cigarettes and the degree of how it's being used in schools. My partner works at a school, everybody's using e-cigarettes there. And so finding these solutions sounds like we need more research to say what works, how do we deliver it? One of the things we talked about is people don't want to tell their parents, right? And so we have this sort of push and pull of making sure that people have access to medications. And we're going to talk about the pharmacy related things there. But I think one thing that Julia said in the intro is one of the goals of tobacco control program is prevention. So what is Rhode Island doing or what's happening nationally to prevent initiation of nicotine use?
Yeah, a few pieces of that are media. So, counter marketing around and education around nicotine for youth. And then another piece is 100% tobacco-free clean air policies. So ensuring that we're addressing the social norms and access to clean air. And then Anne also mentioned T21 is really instrumental in thinking about access to buying tobacco and nicotine products directly from stores. And I did want to add just a little bit of like prevalence in Rhode Island as far as youth, because this comes from 2021. And so we know that we might still be seeing impacts from the pandemic, but what was reported on the youth risk behavior survey was that almost 6% of high schoolers were reporting frequent e-cigarette use. So that's 20 out of the past 30 days. So when Anne talks about like the level of dependency, we are seeing, some consistent usage in folks under 18. And then 32% of high schoolers reported ever using an e-cigarette and 11% of middle schoolers. There is also some data showing that high schoolers and middle schoolers are trying combustible cigarettes, less that they're using them at that, frequent rate like the e-cigarettes, but they're at 12% for high schoolers for ever using cigarettes and 5% for middle schoolers respectively. So we still are seeing initiation for sure. And a few ways that we're thinking about addressing that, for example, in Rhode Island is really promoting alternative to suspension programs. We have a youth and young adult coordinator in the tobacco control program. She's working with Rhode Island student assistance counselors to make sure that they have a program so that when someone is caught vaping in school, they don't just have punitive approaches, they have a way to actually seek and access treatment and education because, nicotine dependency is an addiction. So that's one piece. And then additionally, the state does provide a youth quit line called My Life, My Quit for those 13 to 18. So there's no nicotine replacement therapy, but they do get trained tobacco treatment specialists. And it can be phone-based or just texting. And it's a live person, not a bot. So it's an opportunity to both seek treatment, but also ask questions if you're concerned about a friend or want to know more kind of about the impacts of e-cigarettes. So that's texting Start My Quit to 36072.
I think that's really important that you mentioned concern about a friend as well, because I know a lot of people, like younger generations, I suppose, have friends who do it. They may not, but they want to seek that access or kind of extend that invitation for care and cessation to that friend. They may not know the route to go to access it. So I think that's really valuable that they can reach out for other members in their community too.
So I think one of the things I'd like to kind of build off of what Julia said and kind of what she and her state are doing and states across the country are doing, which is incredibly important. One of the other big things with prevention is really making sure that the draw to tobacco products isn't there. And so one of the couple of ways that the federal government is looking to do that, and as well as state governments in some localities as well, are really removing a lot of the flavored products. We know kids follow flavors. That's what the data consistently has shown us. Back in 2018-ish, maybe 2019, the sale of the pod-based flavors were prohibited, and kids immediately shifted to the disposable e-cigarettes that still allowed those flavors. So we're really excited about a couple of things. There's a number of states, specifically California, Massachusetts, and then DC, which is not a state, but is really cool because that's where I live, and that have eliminated the sale of flavored tobacco products, including menthol cigarettes, which is huge. As well, the next thing I just share is the Food and Drug Administration, FDA, is going through the PMTA process, which is looking at any tobacco product, including e-cigarettes that are on the market, and seeing if they're still allowing them a marketing order to continue to be sold in the United States, the public health standards. So are they safe? And actually, really excitingly, today, FDA denied 2 PMTAs or 2 marketing orders to 2 Vuse Solo menthol e-cigarette products. So those are 2 products that should be off the market after today. So that's a really great way that, really to take away what kids want to use. And then thirdly, I think FDA is also considering 2 rules that I can kind of consider them in tandem to each other, to prohibit the sale of menthol cigarettes as well as flavored cigars. And we know that flavored cigars are a huge draw to kids. A lot of these, to an untrained eye, would easily look like a flavored cigarette. They're much more popular in certain parts of the country than others, and are specifically targeted to certain groups and certain children than others. So, we're really excited to see kind of FDA working on those rules to complement all the work that Julia and her team are doing here in Rhode Island, as well as her counterparts all across the country.
And can you just expand on the menthol cigarettes? We were focused on youth and these flavored cigars. I mean, menthol cigarettes are directly related to decades of marketing towards Black populations, I believe.
Yes, they are 100% right. The tobacco industry, while we know that kids follow flavors, the tobacco industry has been incredibly aggressive at targeting the Black community with menthol cigarettes. As a result, I think it's around 85% of Black Americans who smoke menthol cigarettes. So it's just a really huge disparity that's experienced. We know menthol cigarettes are easier to start because of the menthol flavor masking the really harshness of the nicotine, and then they're harder to quit. So we are really excited that FDA is taking this important step forward. And then the other piece that we're really excited about are things that people like Julia at the state are doing to make sure that there are resources available to individuals who use menthol cigarettes currently that want to quit, in light of the rule being proposed or in light of the rule hopefully being enacted shortly. We anticipate it earliest probably the end of the summer.
Yeah, that was a point I was going to follow up with after, was that it's wonderful to see kind of the ban on these products and a switch away from offering them, especially to vulnerable communities. Then you have to have that follow-up care, provide the things that Julia is working on at state level, that the American Lung is advocating for so strongly. So Julia, maybe you can expand a little more on the quit line. I know you gave us a preview a bit for the younger populations, but what are we offering adult services?
Yeah, so I'll talk about general adult services, and while we're on menthol, I just want to say this year we did launch like a specific menthol protocol. So if someone reports using a menthol product on their intake, they go into a protocol that's specifically designed to address the fact that it's harder to quit menthol. So a couple of things happen. They get access to a more intensive nicotine replacement therapy package. So they're able to get a combination patch and gum. So long-acting patch and short-acting gum or lozenge to help with that nicotine dependence. And that's free, as well as longer coaching. And then they also receive financial reward for each coaching therapy call that they complete to help with retention and promotion of that. So going back to generally, what is the quit line? Every state has a quit line. The majority are CDC funded, but then there can be some supplemental state funding, and programming can vary state to state. Some states are able to be reimbursed by Medicaid or private payers. Rhode Island right now does not have a public insurance partnership for the quit line. So it's all CDC really funded and a portion of state support. So the quit line really is an evidence-based model that encourages clients to make a serious quit attempt with as low barrier as possible. So it's anyone in Rhode Island, regardless of citizenship status, regardless of insurance, regardless of income, regardless of language. It's open 24/7, and it uses trained tobacco cessation specialists to offer at least 5 coaching sessions via phone or web, as well as at least 6 weeks of nicotine replacement therapy for those who are medically eligible. So it's really our state safety net to ensure that people who need cessation services can get them. They can either self-enroll by calling 1-800-QUIT-NOW or quitnowri.com, but it also integrates into the health systems. HIPAA-covered providers can directly refer through fax or secure web portal and receive patient progress updates. So it can connect into the system of care. And we have other kind of specialty programs for those that we know are disproportionately impacted by the tobacco industry. So there's, I mentioned the menthol protocol. There's also a pregnancy postpartum protocol, an American Indian specialty program that really addresses the role of sacred tobacco separately from commercial tobacco, and then a behavioral health protocol. And I know some folks are wary about, phone or online services, but it is effective, and our overall 7-month follow-up quit rate for 2021 was 36%. So that's a strong quit rate. And overall clients report an 89% satisfaction rate. That goes up to 94% satisfaction rate if they ordered NRT. So we know kind of the role of that pharmacotherapy is important in addressing the process of quitting. There's definitely still room for improvement. As a public health safety net approach, we need to be low barrier, easy access, and free. So we can't offer NRT at that full 12-week course. We're not in-person providers, so there's no prescribing of other cessation therapies. So it's definitely still important that we really address our kind of in-person services as well, but it's a really important service that the state has for those that might have other barriers to accessing care, especially.
We were talking earlier, this quit line sounds so amazing. And, the average quit rate is, I think, between 15 and 19% on NRT alone. Someone can correct me on that. So a 36% quit rate is remarkable and shows that, like we see with other substance use disorders or behavioral health, combination of counseling plus medications seems to have the best thing. And so when we talk about some of the ways that we increase access to the medications, we need to be supporting access to those counseling sessions. And then it also sounds like, because that 12-week, just to remind our listeners, the typical course of NRT is 12 weeks, is that they can get that free drug and those free counseling sessions. If you have a primary care doc or some other access to the healthcare system, they'll know how you're doing. We got to make sure that you complete that. And that's where we talk about pharmacy access and other things. I just want to hear from Anne, how are quit lines, what do you think of Rhode Island's quit line, and what are ways we could augment it, or what's being done in other places?
Yeah, so Rhode Island has a great quit line, and they offer really great services. Again, as Julia said, it's really that kind of safety net for everyone to be able to call, again, regardless of your insurance status, and really a way to get access to that quit smoking medication. I think one of the things that the Lung Association would love, and this is to the state legislators in Rhode Island, is more funding for their tobacco control program as well as their quit line. So they can do, so we can have 3 Julias doing, 3 times the work. Because really, that is one way to, huge investment will help save money in the long run and help save lives as well. The other thing I think that's really important that Julia mentioned and Jeff, you've mentioned, kind of touched on as well, is making sure patients that have insurance can get, the full course of treatment through their insurance. The insurance companies, again, for the most part, because of the Affordable Care Act, the state Medicaid program, as well as most private insurance, is required to cover all 7 FDA-approved cessation medications, which we mentioned earlier. The state Medicaid program does cover those 7 medications. So if a patient can get those medications through either their private insurance or through the Medicaid program, depending on what they're enrolled in, that can free up resources at the quit line to help those patients who are uninsured. And so that is one reason that the Lung Association has been improving access to cessation medications with pharmacy prescribing bill in the state of Rhode Island, really to, again, just decrease the barriers to be able to get those medications. Again, these medications are safe and effective to help smokers quit. They've been approved for the most recent one, I think, you're going to make me do math, about 15 years. So, we know that they're safe and effective in helping smokers quit, and we know that when prescribed, they can be obtained with low or no cost sharing.
Yeah, I think the problem is the uninsured population, and I want to move into the bill that we've been championing for a while, which, here on March 17th, we are awaiting introduction into the full House of Representatives in Rhode Island. It did pass committee this week, and so that was exciting. Expanding access to pharmacists as prescribers of all 7 medications. And some people say, well, gee, you guys have been talking about how you can walk into any pharmacy and buy NRT, but you have to have money to do it. And so this allows, in a highly insured Medicaid population, Rhode Island, but like many other states, there'll be 30 or 25,000 people who will be not on Medicaid in a year or so. So we need to make sure both that population and the insured population, like you said, Anne, we really need to make sure that they have access to it. They can walk in when they're willing to do it. We can get them started and connect them to counseling services and the quit line and augment all our services together. Julia, did you want to talk about, I know the health department supported the bill. Did you want to talk a little bit about that?
Yeah, so this bill can really increase access to tobacco cessation treatment. More than 90% of United States residents live within 5 miles of a community retail pharmacy. They have extended hours of operation that include nights and weekends and holidays, well dispersed into the community, and can be seen without an appointment. So obviously very knowledgeable about drug interactions and can respond quickly to the need for drug therapy modification. So providing pharmacists with the ability to prescribe these medications really leverages a trusted and sustainable infrastructure in Rhode Island to increase availability of these treatment options for those who have low income or reduced access to transportation.
So one limitation of the bill about pharmacist prescribing, and it will greatly improve access to tobacco cessation medications, is the huge limitation is it's based on what type of health insurance you have. So if you don't have health insurance, a pharmacist prescribing you a medication, you're still going to have to pay completely out of pocket for it. Medicare, for the most part, does not cover over-the-counter medication, so it would only cover the NRT inhaler, NRT nasal spray, bupropion, and varenicline. So there's still some limitations to it. And again, if your insurance doesn't offer that comprehensive benefit, it's not going to help you as much as it could. Again, the Rhode Island Medicaid program does offer a comprehensive benefit. So for those individuals in the state of Rhode Island, if the bill becomes law, that'll improve access for them. So I just wanted to flag that while it's a really great bill and really important, it's one piece of a much larger puzzle.
And we could pass regulations to have pharmacists make sure they're referring people who are uninsured to the quit line. I think that's the important thing.
I mean, and I think that's part of it, right? You're working as part of a team with the whole healthcare system.
Yeah, go ahead. And
the other thing I just wanted to build upon what Julia had said, and Jeff, what you had said as well, it's the moment that somebody is ready to make the quit attempt. And so, you might be at your doctor's office talking about something, a whole host of health issues or nothing. You're like, okay, I'm good, whatever. I've got to smoke, I've got to lose a little bit of weight, whatever. But maybe a family member had a cancer diagnosis. Maybe you're going to welcome a new baby into your house. So those might be reasons to quit. Or maybe you got a different diagnosis and throughout that process, you're like, oh, they didn't even talk about my smoking or my tobacco use. But when you're at the pharmacy picking up your heart medication, the pharmacist might ask about your smoking status. And that could trigger a reason to make the quit attempt. So that's really important. And that's one of the reasons that making sure that an individual can get those medications when they're ready to make the quit attempt and making that access really easy is so important. Jeff, can I also touch on the other thing you mentioned about a number of Americans and residents in the United States losing their health insurance in the coming months? As a result of the public health emergency for the COVID-19 pandemic, state Medicaid programs got an increase in Medicaid funding from the federal government. And as a result, the states couldn't kick anybody off of Medicaid for almost any reason since March of 2020. So people have had what we call continuous coverage in the state Medicaid program. They have not had to do renewal paperwork. And again, they didn't lose coverage. Currently, states are starting the process to look at every single Medicaid enrollee in their state and see if they are still eligible for Medicaid. As a result, they're going to find people who maybe have gotten a new job and make more money and are no longer eligible for Medicaid. Unfortunately, we also know that they're going to look at people that probably still are eligible but don't have the resources or miss the notification in the mail and will erroneously get kicked off of the Medicaid program. So we are anticipating across the country, not just in Rhode Island, seeing more people uninsured in the state. Their access to market-based plans through healthcare.gov and being disenrolled or kicked off of Medicaid is a qualifying event to enroll in an ACA plan. So would encourage, people to do that, but recognizing not having health insurance, whether that be Medicaid or private insurance, means that an individual isn't going to see a provider. And so they're not going to be asked about their smoking status or tobacco use in addition to any other health condition they have. And they're certainly not going to get advice from that provider to quit, which we know is another motivating factor to help individuals quit.
And from the numbers that I could find, I don't know if these are last year's or this year's numbers, but less than 2% of enrolled RI Medicaid patients utilized coverage for smoking cessation. So opening that door of the pharmacist being able to provide the prescription, start the conversation, even follow up, see that they've filled it in the past and be able to, did this quit attempt work? Is this something you're willing to try again? Could again increase that access, hopefully increase coverage and have ripple effects, reducing load on the quit line and Julia and all the work that she's doing.
But we just need more funding for the quit line because all these things are going to happen. Yes. I mean, to kind of combine
funding and scope is always...
Well, to combine a couple things, my colleagues who are pharmacists and who had smoked have public testimony in our state that say, it was Christmas, Anne talked about those events and it's Christmas and I want to quit. And do you go to your primary care doc on Christmas? No, but who's open? Pharmacies are open. And so if that's a place where you can get that right there, the other thing that I like Anne said is that you're getting your medication for your heart or your lungs. These are things that are affected and worsened by smoking and may not have been mentioned at that visit, but that's we do this with vaccines where every single time you're getting a medication for a diagnosis or those diagnoses, mention all these other public health interventions that we can do. And the second thing is what we started with is this mental strain, the mental concern index. Losing your health insurance, and there are people who are losing their SNAP benefits. These are previously called food stamps in an era of very high inflation among grocery items. There's a population that is going to be very, very much struggling, falling into poverty. And ironically, they're the population we just talked about at the highest risk of starting and maintaining smoking. And so this is honestly sort of a very important moment for expanding care to prevent these illnesses, to prevent hospitalizations, to prevent deaths, and prevent people from starting smoking by trying to expand the safety net and trying to keep people on insurance. And pharmacists have done that as well, to trying to get people to be on Medicaid and other insurances.
Jeff, you mentioned that the health department is underfunded and the quit line is underfunded. And I'm just going to throw some numbers to kind of underline how much more we really need to do in the state of Rhode Island, and frankly in most states across the country. CDC has best practices as what a fully funded tobacco control program should look like in each state, looking at the population, the demographics, the number of individuals who use tobacco products. CDC recommends that Rhode Island spend $12.8 million on tobacco control. Currently, the state legislature allocates $400,000 to that program. So we are talking about a huge gap. There is legislation right now in the state of Rhode Island to increase the funding both immediately and then slowly to get it up to that 12.8 million over the over a number of years. And so really kind of thinking through, if we really want to help people quit, and if we really want to put our money where our mouth is, and we know the tobacco companies are spending, I don't know how much money, probably millions of dollars in the amount that we've just been talking for the last, 40-ish minutes. And so we need to make sure that we are doing everything we can to help countermarket that and giving the state tobacco control programs here in Rhode Island, as well as across the country, really the resources they need to be able to do that effectively.
Well, so we need to talk about the regimen and solutions, I think, before we run out of time here. Jake?
Yeah, so Julia and Ann, what is the regimen for tobacco cessation and smoking cessation, both here in Rhode Island and nationally? We'd love to hear your take.
So generally, overall, the CDC talks about tobacco control vaccine. So that's kind of the gold standard for addressing tobacco. So there's four main components to that: tobacco prices, smoke-free policies, media campaigns, both to promote quitting and to prevent initiation, kind of counter campaigns, and then cessation access. So thinking specifically about cessation access, which is a big part of what we've been discussing today, a major step for cessation access would be that bill we discussed earlier, allowing pharmacists to prescribe the cessation medication. And then additionally, more provider education and support. So I do want to note that the tobacco control program offers a on-demand provider training platform with free CEUs for registered nurses, physicians, and pharmacists. So it covers various topics from cessation coverage 101 to screening and counseling for e-cigarette use and behavioral interventions. So that's just one example. Also thinking about how we can help every type of provider at every visit do at least the brief intervention of what we call AAR, asking, advising, and referring. And doing each of those steps, not just the asking, but also really connecting or referring to an option. So those are some steps for cessation access, and I'd love to hear Ann's thoughts.
I think Julia is 100% right. I think Rhode Island is, in a lot of ways, leading the pack, but still has some work to do. I think one of the things is close the smoke-free loophole with currently casinos in Rhode Island. You can still smoke indoors. However, otherwise, with that exception, all other workplaces are smoke-free in the state of Rhode Island. However, that is not true nationally. There are a number of states, more than you would think, and I apologize, I don't know the number off the top of my head, but we can put it in show notes, that still allow smoking indoors in bars, restaurants, and other workplaces, exposing people both to allowing people to continue to smoke, so not encouraging them to quit, as well as exposing workers and others to secondhand smoke. Again, Rhode Island has expanded Medicaid. There are fewer people without insurance coverage, so it's easier to get access to those cessation medications. Again, that's not true across the country. There's a huge coverage gap, especially in the southeastern part of the country. So really, it's that tobacco control vaccine that Julia talked about. There's much more to be done to continue to, frankly, battle the tobacco industry. They have a lot of money. They like to spend it, but we're not giving up. And I think it's going to take everybody, and it's going to take a concerted effort. Pharmacists are one piece of that puzzle, but it is not one group alone. It is everybody doing it together. We've got to be out there ahead, ready for the next product that they're going to put on the market that we can't even imagine right now. I think one of the things that I'm seeing that's very scary is in states like California that have prohibited the sale of flavored products, trying to get around flavors, which I didn't even know was even possible. It's not actually a mint flavored, it's like unicorn flavored or something like that. And who knows what a unicorn tastes like. So it's just really trying to make sure that we're one step ahead. And then again, just going back to the basics, because we know that those work.
Yeah, we got a long ways to go. I think one of the things we try to do is to get public support. And I always tell folks, the personal anecdote is when I was much younger, 20 years ago, I think it was 20 years ago, 2003, right, Julia, when workplaces and bars went smoke free. And it was just like overnight, I went to a bar and people were smoking and my clothes stunk and it was horrible, but that was my experience. And then like a week later, oh, wow, this is actually a pleasant experience to not have people smoking in the restaurant or to have to ironically walk through a smoking section to get to the non-smoking section in a restaurant, which, as Anne said, still exists in lots of other places. And so all of those things, I think, are ways to say, like, isn't it a better environment that you're not around this? And sort of what Jake was saying earlier, too, is tell people about the quit line or call it yourself, get those assistances. We do this with other addictions where we see it as a societal and family approach to say, hey, do this. I remember one of my students saying the only reason my parents quit smoking is I told them to do it, or, when I was 9 or something. And I think that's, it's those kinds of efforts that need probably more than $12.8 million a year that we need appropriated to have sort of a whole of society view on smoking cessation.
And I just wanted to say thank you for drawing that correlation to tobacco and other substance use disorders, because for a long time smoking was really framed as a bad habit, and it's not. It's an addictive substance that requires proper support and treatment to have successful recovery. So when we think about the regimen, we really need to be thinking about ways to use the best practices for successful recovery. So counseling and medication, and in combination, ideally. Quitting is really hard, but it's not impossible. And as Anne said earlier, the majority of people who smoke want to quit. So we can't just say, well, it's a motivation issue. I mean, motivation is hard. If you've ever made a behavior change, it's hard, but that's not the crux of the issue. We only, about 31% of those who do try to quit really use an evidence-based cessation treatment. So we need to increase access and support use of those evidence-based.
We have the tools. We just got to use them. All right, Julia Doherty from Rhode Island Department of Health and DeJulio from American Lung Association. We want to thank you guys for being on, and thank you for being such passionate advocates on this topic and breaking everything down for us. Be sure to follow us at PharmD.PubHealth on Twitter and Instagram. Subscribe to us over on YouTube, Spotify, Apple Music, Apple Podcasts, anywhere you stream.
Leave it in.
PharmD.PubHealth. We'll catch you next time. Thanks for listening.